Hello, everyone, and welcome. Thank you for joining us for today's presentation, A Physician's Perspective on Medical Aid in Dying, presented by Compassion and Choices and hosted by the American Society on Aging. I'm Julia Burrows, Thought Leadership and Impact Manager with ASA, and we are so glad you are here. We will begin shortly, but before we do, we have a few housekeeping notes. I would like to direct you to the left side of your screen where you will see 5 tabs labeled Speaker Bio, Important Information on Group Viewing, CE Application, FAQ, and Event Resources. The slides for today's presentation are available for download under the tab labeled Event Resources. You will find information on how to obtain CE credits for this event under the CE Application Here tab, including links to the application and to the step-by-step CE guidance webpage. We have changed our CE application process, so please take the time to review the guide before submitting an application. You will be able to access the CE application after about 2 hours of the live webinar completing. That is time for us to receive and record the attendance. It may take a little bit longer with a large audience like we have today. We appreciate your patience. Please be aware that your time is logged and you must view the entire long webinar to be eligible for CE credit and to access the application. If you are not logged into the webinar directly using the email address you registered with, then you will not be eligible for CE credit as we have no way of tracking your online attendance. If you registered before the live webinar event today, you will also receive a follow-up email by the end of the business day that will direct you on how to claim CEs and include links to today's slides and recording. You have 60 days from the live event to complete a continuing education application. If you have any questions during today's presentation regarding the webinar, you can send those to us at any time using the Ask a Question box, and we will do our best to get to those questions in the last few minutes of today's program. And now I would like to welcome our presenter. Dr. Cory Carroll, is a practicing board-certified family physician and one of 2 part-time national medical directors for Compassion and Choices. Prior to medical school, he was a commissioned officer in the United States Air Force, stationed at Wright-Patterson Air Force Base in Dayton, Ohio, assigned to the Air Force Aerospace Medical Research Laboratory. We're so excited and grateful to have you here with us, Dr. Carroll.
Well, thank you, Julia, and I'm grateful to be able to present and thank the ASA for this opportunity. I think it's timely since this concept. I think if you don't know about Compassion and Choices, and I'll tell you what, let me do the slide. So I'll go to the next slide, which we've already heard a little bit about. This is me. Probably nice we don't have video. My mugshot is not the greatest in the world, but I have been a family doc for 33 years. Prior to that, I was an engineer, and kind of an interesting combination, but it worked for me. And it was just last year I became National Director for Compassion and Choices. If you don't know, this organization is the oldest, largest, most active national nonprofit organization dedicated to improving care, expanding options, and empowering everyone to chart their own end-of-life journey. And there you see the website has lots of resources. I would encourage people to go to it. And we're going to focus on a specific topic today, but when you look at the options at the end of life, I was just presenting to our county commissioners this morning and discussing a case, not because they were medical providers, but how aggressive treatment we have for, say, colorectal cancer. So there's amazing options in medicine that can help us combat disease and treat, infections and cancers and heart failure and renal failure. And obviously, all of us in medicine want to help people, and we want them to do well. But it really boils down to what does the patient want and what are the circumstances. So some patients at the end of life choose not to pursue treatment, or they pursue treatment and find out it isn't working and they can discontinue treatment. Obviously, if they're at the end of life and there's clear prognostic indications that they will likely die in 6 months, hospice can be brought in. There's the concept of voluntary stopping eating and drinking, so that's another way for patients to control their end of life. Palliative care, conscious deep sedation can also help when there is intractable pain and suffering. And in states that have authorized this, there is now medical aid in dying, which I'm going to focus on today. Basically, it's a terminal ill adult who has medical decision-making capacity, a prognosis of less than 6 months to live, under their own volition can request and receive from their physician, a physician that participates, a prescription medication that they ingest consciously on their own, if and when they deem their suffering to be intolerable. Well, we won't go into too much detail, but I get a lot of folks say, well, we can control pain. And I go, well, pain is one form of suffering. Other forms of suffering are being sedated to the point where you can't communicate with your children. So it's again, autonomy, it's the patient's decision, and they're the ones that make this decision. Obviously, if they can't make the decision because of dementia or even a delirium, if it's not cleared, then they do not qualify. So they have to be able to demonstrate they understand what they're asking for, which is the capacity. They need to have that capacity at the time of ingestion. And you can't ask, well, gee, I have a durable power of attorney or my loved one. This is what my mom asked for, before she was in the Alzheimer's unit. That doesn't work. The patient has to be able to literally talk to the provider, talk to the individual to tell them what's going on. No advance directive is accepted with the laws currently. Here's where medical aid in dying is authorized. And not a large geographic distribution, but due to the population in some of these areas, it affects 1 in 5 adults. And we'll talk a little bit about residency, but most of the laws, all of the laws initially said you had to be a resident. That's changed a bit. Oregon was the first. Long time ago, 1994. It took several years, probably 1997, before it really launched due to court battles and people that were opposed. But Oregon began this way before anybody else, and tremendous amount of data has been collected. Washington, Montana doesn't have statute, but the Supreme Court weighed in, so that's one unique state. But the rest of the states, Vermont, California, Colorado, District of Columbia, Hawaii, New Jersey, New Mexico, and Maine have all statutes and jurisdiction. I'll go over that. Colorado, the law was signed in by Governor Paulus in 2016. That's where I live. That's where I practice. And I have helped patients in Colorado with this process. So the fundamental eligibility requirements, basically in all the laws, an adult, terminal illness, prognosis of 6 months or left to live. That's very similar to what qualifies you for hospice care. Again, mental capacity, acting voluntarily, and able to ingest the medication. Residency is interesting. Initially, you had to be a resident of the state, establish residency. People have moved. Brittany Menard, the famous case with the brain tumor from California, moved to Oregon to utilize this law. Because at that point, California didn't have the law when she had the tumor. But in Oregon and Vermont, in this year, the residency restriction has been lifted. So people can move to those states, but it's not easy. There's a whole litany of issues that you have to qualify for, and you still must ingest the medication in a state that authorizes it. You can't pick up the prescription and go back to Texas, for example. The typical process is patients will make an oral request. There is usually a statute that requires a written statement. We'll talk a little bit about that. As a family physician, I help patients with gee, we have this new diagnosis, we have this new disease process, let's get you to the imaging center, let's start getting consultants on board. Obviously, at this stage, most of the patients have gone through multiple physicians, multiple actions and treatment plans. Many have been diagnosed with cancer decades before, and unfortunately, the remission has failed, and now it's back in force, and there's no effective treatment, or patients are just saying, I'm tired. So when the patient says it's time, there is an attending physician who must be willing to do this. So all the states, it's optional for the prescribing physician, for the consulting physician, for the pharmacist. So once the patient has found a physician that's willing, the request is documented, the patient is evaluated, obviously, for eligibility. And this is a great opportunity for physicians to talk to patients, not only, oh, this is medically dying, you're requesting. Well, let's talk about what's happening. What areas of support can we provide for you? What are things? Maybe we need to get hospice involved, palliative care. How about getting some home care aides? So it opens up the dialogue and gives us, again, better care at the end of life. Options to hospice go up in states with medical aid in dying, and the informed consent is obviously important to obtain. The next process, it's not always written in law, but there needs to be a consulting physician that confirms the diagnosis. And this is not as extensive. They just need to say, yes, I have a patient here who does have a terminal illness, 6 months to live, mentally capable, not being coerced in their opinion. And they've been made aware of all the options, and the consulting physician nor the attending physician have to agree with the patient's decision. Obviously, we that are willing to do this have to be okay with the process, but this again is the patient's decision. Once those items are documented, then the process can move to the next step. Now, this is critically important. People say, well, what about those patients that are depressed or confused? Well, I've been approached by several patients, and they obviously don't qualify for the law, so I don't ask for a psychiatrist or a psychologist consult. That's clear that they're not going to qualify for the law. So if they don't have a terminal illness, they don't have 6 months to live, regardless of their situation, this law cannot be implemented on their behalf. However, if there is some question in either the attending or the consulting, there is in statute that the next step would be to get a psychiatrist or psychologist to determine capacity. Again, we're not looking at their ability to make really complex abstract thought, but do they understand what the diagnosis is, what the prognosis is? Do they appreciate the circumstance they are in? Do they appreciate and understand the medications that are given and what it will do? Do they have a rational thought of this will, if I take this medicine, will end my life, a life that I've been told is going to end likely in 6 months, do this process, and then communicate that back to the mental health professional. And then again, it's not for all aspects of their life, it's for this specific issue. So assuming all those have been accomplished, the attending prescribing physician makes sure that all the boxes are checked off, and each state has different waiting periods and lists and forms that need to be put in. But this is the time where the attending physician makes sure the patient is aware of the risk or the benefit. This is something that the patient can stop at any time, can not take the medications. There's no absolute that says once you begin this process that you have to follow it through. You can stop at any time, or even if you complete the process, you don't have to take the medication. And then I think it's important to encourage support, including the family members. Hopefully there is hospice involved. Some hospices participate, some don't, but they're all going to support the patient and the families in this process. And without saying, those of us that help patients at the end of life, hospice is a godsend. It is perfect to provide the spiritual support, the music, the aides that can come in and help bathe the patient, the different things. They don't have full care, but it's really a wonderful service at the end of life. And I encourage all my patients and any physician that asks me to make sure that hospice is involved if the patient is willing to have that done. As I mentioned, in the various states, there's different forms and different residency restrictions. California has a 48 waiting period. Colorado has a 15-day waiting period. I believe Oregon says, well, it's 15 days, but if the physician feels this needs to be expedited, we can go to 48 hours. And that's up to the physician to make that the definition, mental health assessment. There's only one state that's absolutely required, and that's Hawaii. And when you look at the evidence, there isn't a lot of involvement in mental health. And some people think that's a problem, but it just goes to the fact that the family physician, the internist, the specialist, they're very, very good at assessing a patient's capacity, understanding. It is not that, again, people don't walk in off the street brand new to a practice and say, hey, I want this medical aid dying. That's not how this works. Usually there's a long-standing relationship, and it makes sense to everybody that's involved. Medical aid in dying is optional for all clinicians. That's in all the statutes. I don't want that to change. I have colleagues that think this is not aligned with their professional ethos or their views on life. That is perfectly fine. I, on the other hand, am comfortable with it. So I do not want to force my colleagues who are opposed. Thus, I don't want them to tell me this is illegal. It's critically important because that protects the physician. It's also important because the insurance benefits, including life insurance payments, can't be denied. And what goes on the death certificate with medical aid dying is not medical aid dying. It is the underlying cause of death. So that allows that to go into the record so that it's kept as this is why the patient died. All the laws are very clear. If there is any attempt to coerce, exert undue influence, move against the law, that is going to be prosecuted. So the current protocol, I really didn't want to go into detail because these have changed. When I first started, it was different, but here's the current protocol. Prior to ingestion, there are two medications that try to mitigate nausea, vomiting, and also improve gut transit. And there are some red flags with medical aid dying, and one is to have a healthy gut. So there are clinicians that are involved. I'm one of the two national medical directors for Compassion and Choices that can counsel physicians on the red flags, walk them along if they're not comfortable with it. There's another group called the American Clinicians Academy on Medical Aid and Dying, acamade.org, and they have physicians and lots of resources for physicians. And this is what helps us determine this protocol. So this is based on science. So after the medications are taken, this cocktail, and it is a mixture, it needs to be completed in a compounding pharmacy. For those of you that are not medically inclined, these are whopping doses of medications. When combined and absorbed, critically important, it needs to be absorbed, they will depress respirations, they will depress cardiac function, and eventually death will ensue. As I mentioned, this is a compounded process. It can actually be down into 2 ounces, and that's the current recommendation. It does have a little bit of a bitter taste if people are swallowing it and access their tongue, but that can be mitigated with a popsicle or sorbet. But this has to be done through a compounding pharmacy. And I have always stipulated with my patients, once they've qualified and gone through all the hoops, they don't get the medication. It's only when they're ready to take it. And I've had patients that say, thank God I've qualified. That takes a relief off my chest. Now I can move on with my life. They never fill the medication. Obviously, all medications are dangerous. This is one that's exquisitely dangerous. So we don't want this to be just laying around. We definitely want to have very good control of it, and that's where the families come in. Hospice does a great job at making sure medications are accounted for when the patient dies, etc. The next slide is for those medically inclined in the audience. There are different ways of administering this. Now, you have to understand when patients are at the end of life, there are many different reasons. One, maybe colorectal cancer, and they are not able to actually eat or swallow well. They may have a neurodegenerative disease such as ALS. Those individuals typically, when they lose their ability to swallow, have a permanent tube placed through the skin of their abdomen into their stomach so they can be fed. That's the route of administration. The nasogastric tube, it can be placed so if the patient can't swallow, these two devices can access the upper GI tract and deliver the medication there. And there's also a rectal catheter. The rectal mucosa, surprisingly, is very capable of absorbing the exact formulation we're giving in the upper GI system, and it's quite efficient. So if they don't have a PEG tube, if they don't have an esophagus, or their esophagus is not functioning, they can't swallow, rectal administration is important. The other piece of the law is they have to administer the medication. So when you're swallowing, a family member, an assistant can hold the medication. They can have a straw in their mouth and drink it through the straw. They need to push the syringe if it's going in one of these other methods. So again, the patient is initiating the medication. And there is no injection by a physician. Canada, Belgium, Colombia, Luxembourg, Netherlands, New Zealand, Portugal, Spain, and all 6 states of Australia have laws that look at this and see, well, this is another rational way in that country to help patients at the end of life, not in America. No laws are allowing this to say this is euthanasia or this is delivered by some other individual. So once the medications have been introduced, again, some red flags if they have a dysfunctional GI system, if they haven't eaten for weeks or months, that could have a significant impact. But these medications, again, are very effective once they get absorbed. Falling asleep, 10 to 30 minutes, they don't wake up. Heart and breathing stop 30 minutes to 1 hour. The data that's collected through the ACMAID site shows, and these are clinicians from all the states that are providing these data points, 85% of the patient with that above regimen I gave you will pass within 2 hours. A few will last longer, so it's critically important if you're a physician that is prescribing this not to give expectations to family. Oh, they fall asleep and then 5 minutes later it's over. This can be a longer process, but there's no data that shows that it doesn't work, especially if you're making sure you're looking for the red flags. Now, this is the other piece. I get frustrated when I have colleagues telling me, oh, this is physician-assisted suicide. This is patient suicide. And, you know, I don't want to get into the semantics, but in the legal profession and in the statute, we clearly delineate this is not suicide. A couple things to really think about. In medical aid and dying, these are patients that have been told, typically by multiple doctors. Many have been in clinics that have been treating for cancer or heart failure. They've been on dialysis. They have a terminal diagnosis. This didn't happen yesterday. They've been living with this disease typically for months, if not years. They have to have mental capacity. All of the patients that have asked me for medical aid and dying do not want to die. I repeat that. They want to live. They have families and children and grandchildren. They don't want to die, but that's not an option. They are talking to their family. Usually hopefully in functional families, this is maybe controversial, and there'll be members that are, you know, very sad and upset, but they support the loved one. and the death is peaceful. I'll talk a little bit about that at the end. Suicide on the hand, they don't have terminal illness. I mean, it's possible, but most of the suicides we think about, they are not being told by the medical community, you have a terminal illness, 6 months to live. They're mental impairment. They literally want to die. It's potentially short-lived. It may not be logical, but that's their intent. They do not involve the medical community. They don't involve their families, and death is often violent. Extreme difference in how this approaches, and I think it's important for the families and the patients to look at that. For that reason, in the statute, we make it clear that medical aid in dying is not suicide, it's not assisted suicide, it's not mercy killing, elder abuse, homicide, or euthanasia. And even though there are colleagues of mine that would disagree, I will tell you the benefits are profound. Peace of mind for those that wish. Again, patience, it's optional. A very small portion of individuals at the end of life choose this option, but it can be incredibly peaceful for them to know. There's open communication, again, increasing the use of hospice and palliative care. And I would argue there's a positive impact on the doctor-patient relationship. My colleague, Dr. Grube, had a slide that said, mortality is 100%. And that's true. I think Benjamin Franklin said death and taxes are the only thing unavoidable. Well, guess what? I think people have figured out how to get out of taxes. But death is always going to be there. And when we've exhausted all resources, it's so nice to have this as an option. Nuance. Medicare will not cover medical aid in dying. The VA will not. The federal portion of Medicaid, federal government employees insurance. But it can be covered by, in some states, the Medicaid component and some private insurance. And this is typically looking at the medication. The doctor's visits are typically going to be billed under the terminal diagnosis and under support, end-of-life care. And there's not a statement that says, all I'm going to talk about is medical aid dying. We usually are always looking at the entire picture in the exam room. So here's the data from the 10 states and the district with a cumulative 60 years when you line them up. 6,522. Sounds like a lot, but that's less than 1% of the deaths that have occurred. And you can see 64% of that total number ingested, which means 36% did not ingest. It could be because they lost capacity, they changed their mind, but usually this is because they made that decision. The demographics show it to be educated, white, older. Hospice enrollment is a whopping 85%, and the most common diagnosis are cancer and ALS. The physician prescribers are increasing in all the states, and this is a good thing. We want to normalize this, again, for those colleagues of mine that are willing to accept it. The medical considerations, ethical considerations, this is where you begin to ask the question, well, is this the right thing to do? And once again, I kind of ask the question, well, who's making this decision? If they are competent, if they are aware of the circumstances, is the patient's choice to make this choice. And that's how I feel. I don't want to force my belief system, my views on anybody. And I had a wonderful colleague who's actually a lawyer and a family doc in Nevada. He's actually an assembly person there, Dr. Ortelanger. And he's brilliant at discussing this, but I'll do my best. But I think that, again, back to the autonomy of the patient, do no harm is fascinating. I've had legislators and other physicians saying, but you're not following the Hippocratic Oath. And I go, well, every time we prescribe medication, there could be a side effect. That might be harm. Do we not prescribe medication because of the potential harm? Once again, what is the outcome that's going to occur in this? And nobody can be 100%, but we're fairly clear that these are patients that are at the end of their life. Beneficence is the quality or state of doing or producing good. Once again, whose eye is that? And that's where I go back to number one, patient autonomy. And Dr. Ortelanger could explain a little bit more about justice, but unfortunately, as I mentioned with the previous slide, The group of patients that are utilizing this are educated, they're affluent, they're white. And I don't believe for a second they're going to say, oh, I'm going to do the worst thing and I'm going to make mistakes. They understand the benefit of this. They understand this. And, not that I ever want to impose anything on anybody, but it would be nice if we had better access to healthcare in general, but making sure that everybody understands this option. I'm going to actually show this next slide. Unfortunately, we were not able to go into or embed this video, but we'll put this in the chat or in the question. Julia will do that. But this is a ER physician who does a brilliant job of explaining how she sees this. She's an ER physician. And I'll encourage you to watch that at some other time. We have other documentary clips on Compassion Choices website. But I'm going to briefly talk about a few of my patients. Unfortunately, the most updated slide set didn't get in, but I will just do this because I don't want to get too deep in the weeds. But my first patient was a 91-year-old male who had congestive heart failure. Now, he was not my long-term patient. He sought me out because he couldn't find a doctor. Early on, this was in 2018. Again, the law passed in 2017. I think he approached me in 2016 in Colorado. He approached me in 2017. And his quick story was, he said, Doc, I made a mistake. I went to put on my ski boots. Remember, he was 91 at the time when he died. He was like 89 when he tried to get his boots on. And he said they didn't fit. And instead of going to the ski shop and buying new boots, I went to the doctor. Well, obviously, he was in heart failure with dependent edema, and this was due to a kind of rare condition called amyloidosis. But they tried to put a pacemaker in and ended up with complications. But the bottom line, this is a protein that fills and begins to stop heart function or decrease the ability for the heart to pump. And he, as you can understand, is an active man. Skied somewhere in the neighborhood of 120 days a year, believe it or not. He rode his bike, he was hiked, he worked in his yard, he was an avid gardener. Now, all of a sudden, he's short of breath going to the bathroom. And he was clear that this is not what his end game was going to be, just to get worse and worse and worse. And I met with the family and I met with the children, and two children were not totally in agreement, but they supported their father. They knew who he was, and he was very, very clear. The day of ingestion, I went to their house. Hospice was there, although she wouldn't be in the room with the patient. But we were surrounded by his family, and we had a wonderful conversation. Tears were lost. And the patient kind of joked. He said, yeah, when the medicine got here, I wanted to see how bitter it tasted, so I took a sip, and I go, oh, my gosh. He said, isn't that bad? So we went into the bedroom, and his family joined him, and they sat on the bed with him. He drank the medication, and as he was slowly drifting asleep, telling everybody how much he loved them and how much they loved him, he went to sleep. As I mentioned, he had a pacemaker, so it took a little bit longer for this process to occur, but within about 40 minutes, there was no discernible heartbeat, and respirations had ceased. And every single one of the children hugged me and thanked me to help their father through this process. So it's that interesting dynamic of, wow, this is terrible. We're hurting people. And the argument I make is, no, we're not. The second case is basically an ER nurse, and her husband was an ER physician. She had, it was a missed appendiceal carcinoma, very rare, but on the appendix of her large bowel, there was a cancer that was missed, and by the time they caught it, she had aggressive disease. She went for years as this disease progressed, losing weight. She had ascites, which is buildup of fluid in the abdomen. Obviously getting treatment, doing everything she can to stay alive. We actually had to put what's called a peritoneal shunt in to take the fluid off on intermittent basis because it was so uncomfortable for her. And she finally made the decision. Now, remember I said that red flag? She was one of them. She had a pretty messed up gut due to the metastatic disease in the colon. She had metastatic disease in the liver. So her ingestion we were very cautious, making sure that she could ingest the medication. And it took about 3 to 4 hours for her to finally pass. But her husband was on the bed with her. Her dog was on the bed. Her son was in the other room, a little uncomfortable being there. But again, this was a marvelous way to end a life that was ending. And I've been in the intensive care unit when I was early in my training. I've been doing CPR on people in their 90s and watching them go into these really aggressive hospital rooms, intensive care units, ventilation, cardiopressors. I just don't see that as a compassionate way when you know someone is dying. When you think they can be resuscitated and they can be revived, absolutely, let's do it. So I'm going to move on because I think I was hoping we could watch that video, and I hope you all take a look at that at the end. But for more information and resources, I urge you all to visit Compassion and Choices. There you can see, again, the documentary that I've had on the previous slide, and we'll put that up so you can look at it. And many more resources. There's a dementia toolkit. Remember, medical aid in dying does not, patients with dementia do not qualify for medical aid in dying, but Compassion and Choices understand that as dementia is getting a larger percentage of diagnoses in the United States, it's important to think about it and begin the discussion with your family and documenting your wishes. And this is just another piece of that. So Compassion and Choices has a lot of options for those at the end of life, and I would encourage you to go there. So Julia, I see some questions.
Absolutely. I'm gonna start pitching them out to you if that's okay. we do have questions in the queue, and if you have any questions, now's the time to put them in that question box. One of the first couple of questions that we received is actually about the cost of the medications themselves. If somebody were expected to pay for these out of pocket, are we talking thousands of dollars, hundreds of dollars? How accessible is that?
Yeah, and that's a great question. It varies tremendously, as everyone knows, depending on the pharmacy. And as I mentioned, there are some insurance companies that will cover the cost of these medications, but most won't. So if a good example is when Oregon passed a law in 1994, 1997, when it was administered second-to-barbital. A barbiturate was the medication, a lot of it. And it was very inexpensive, less than, I think, $100 at the time. Well, when California passed the law in 2015, the price went to $3,000, and then that medication was taken off the market. So obviously, the physicians that are working together and coordinating this, shout out to Acamade and all the research that they've done. The protocol that I provided you up front, including the pre-medications, varies. Probably $500 to $1,000 is the out-of-pocket cost without insurance.
Fascinating. And along the same lines with medications, what happens if a patient, that 30% that ends up not taking the medications, do you return it back to the pharmacy? What is sometimes hospice responsible for disposing it? How does that work?
Right. Well, like any other medication, I mean, if a patient dies and they have, bottle upon bottle upon bottle, any disposal location, typically there with the police department, the pharmacy, I've offered for my patients to dispose of the medication, but it just needs to go to a medical disposal site, and they will basically make it, I don't want to say harmless, but they'll put it in a place where it can't be harmful to others. But that is an important concept, that, and that's again why I reiterate, most of my colleagues that prescribe medications are encouraging their patients, okay, now you qualify, and if it isn't imminent that you're going to die, and you're going to say, oh, I want the medication, as soon as I get the medication, I'm going to take it. Most are just wanting that peace of mind. And the other piece of this, which I'll kind of weave in here, is this this discussion allows us to bring up these options early on in the process, so you're not at the end when there is incredible pain and suffering. I mean, hospice always is saying, please, when there's clear indications, let's get them involved with hospice because that can give them better care. So the medication process, if the patient is ready to take it, great. Once they've taken it, that's all there is to it. If they decide not to take it, then it is critically important to have the hospice nurse, the family member, the physician follow up and say, by the way, let's get those medications and dispose of them properly.
And you touched on it just here, but I think we might want to elaborate. Can you explain the difference between hospice and palliative care?
Certainly. Hospice requires a prognosis of 6 months to live. Obviously, there's a terminal illness in there. Palliative care does not. Palliative care can be involved while patients are, and again, the other component, although this looks like it might be changing in the federal statute, but hospice has really intense rules. And one of the rules is the patient has given up, has not pursued or has ended the aggressive life-saving treatment or potentially life-saving treatment. So with hospice, if you're, say, getting chemotherapy for colon cancer and that chemotherapy is intended to cure, which is great, well, you can't be enrolled in hospice. It's only when you say, right, I'm not going to pursue the chemotherapy, I'm not going to pursue the radiation therapy, I'm not going to go after aggressive surgery. That's when hospice is utilized, and the intent is to help them peacefully die, transition, usually within 6 months. Palliative care, the patient can be aggressively having cancer treatment, can be aggressively having surgery. And the palliative care team is typically a primary care physician, family doc, internist, could be an oncologist. But these are folks that understand that there's more to taking care of people who are suffering than just here's your opioid. And palliative care in the correct setting can offer the terminal sedation, palliative sedation, if there's no other way to help the patient with suffering. But palliative care is independent of hospice and can be utilized even if they're aggressively getting treatment, but their symptoms are not under control. And that's a wonderful combination to have for patients when they say, yeah, I'm not ready for hospice, but boy, I wish I had something to help me. Again, my specialty colleagues, cardiologists, nephrologists, oncologists, they're great at helping people. But having that additional team with the palliative care is a very, very positive process for patients.
Perfect. Thank you for that. We have had a couple extra questions come in about how it works when a patient is diagnosed with dementia or Alzheimer's, and how that may complicate medical aid in dying.
Well, obviously, if they are unable to make competent decisions at the onset, they don't qualify. And there are conditions, ALS, Lewy body dementia. I mean, early on, people are capable of making decisions. And another interesting point in this concept is the criteria and the American rules of self-administration. So think of an ALS patient, that's Lou Gehrig's disease, and that's a terrible disease where they lose motor control and they are eventually wheelchair bound, and they sometimes, well, they almost always are unable to swallow, and they'll have a peg tube. They'll sometimes need respiratory support, CPAP, BiPAP, different things to help keep them alive. But if they can't initiate the medication either, and it gets kind of dicey there. So physically being able to initiate the medication, mentally being able to document. And that's the sad news with ALS. They are mentally sharp. They know exactly what's going on. They just have lost in stage the capacity for motor control. But even if they have a little bit of motor control, that could be enough to initiate the process. But if they have dementia, this law cannot be pursued. If they present and they have a condition, say, and I had a patient who had melanoma. He actually sought me out way before I diagnosed the return of the melanoma. But he said, I know your position on this. You're my doc. I want you to be there at the end. I said, you got it, but let's not worry about it. Well, here's the interesting thing. He showed up for a physical, and I felt a big lymph node. I go, we need to end. It was on the same side. He had the melanoma removed, and he didn't have aggressive treatment back 5 years before that. And he said, okay, time for the medication. I go, no, you don't qualify. I don't know exactly what this condition is. I can speculate, but how about if we get a biopsy? And he allowed me to get a biopsy. And sure enough, it was melanoma. Now we know it's metastatic. I said, okay, time for the medication. I go, no, wait. Just you have a wife, you have a kid. Let's talk about some options here. And I finally convinced him to go to an oncologist, and he had 2 years of quality life with pretty minor chemotherapy. But he finally ended up, and there were metastatic disease at the end. He had brain mets. Well, I went over to the home. His wife was there, and there's no chance that he can make a medical decision. He had hospice involved, and we had the medications that hospice prescribed. But I took his medications that he picked up for terminal end of life, and I brought him back to my office to dispose of, because he could not make that decision because of his mental incapacity, because of the brain mets of the cancer. So those are some of the confusing parts, but you need to have that mental capacity at the initiation, at the request, and also at the ingestion. If you don't, the medication should not be given.
That's really interesting. There's more questions about the access to this as an option. Do you expect more states to expand their laws to allow for medically assisted aid in dying?
Right. I'm not going to go back to the slide because that'll get everybody dizzy. Well, maybe I can, because I can flip up here and look for it. Yeah, so this slide shows the progression of introduction. And I don't have the polling data in this presentation, but gosh, Republicans are in favor of this, Democrats are in favor of this, Catholics are in favor of this. Now, the Catholic Church is absolutely opposed, but when you poll citizens, they see this as a viable option. Now, not all will choose it, but they look at it as something that we're in America, the land of the free. Let's allow for options. So yes, we anticipate, and one of Compassion and Choice's advocacy work is to help states. My job, I will go talk to medical societies, American Academy of Family Physicians, the medical society in the state. I will go to the legislation. My colleagues in Compassion and Choice, and will try to clarify. Again, what I'm doing here for this group is saying, this is not an evil, terrible thing. This is actually a beautiful thing. That is a wonderful way to help a patient die who is going to die. I was on a talk with Braver Angels about a month ago, and it's fascinating. There was a large group of people speaking, and the folks that were proponents of this all had experiences. They said, oh, my mother went through this, my father went through this, my aunt went through this, and I didn't. Now, not everything is going to be perfect, but the interesting thing is the opponents were all speculating. Well, this law is going to, take out the demented. It's going to take out the disabled. I go, no, it's not. And all the data shows that we do not see a slippery slope. We do not see misuse. We do not see elder abuse. It's even harder, if you think about it, to get two doctors to agree that a patient is terminal illness, 6 months to live. If you're disabled, you don't qualify for the law. But if you're disabled and have a terminal illness and 6 months to live, and it's your choice to use this law, well, then I'm not going to discriminate. You certainly have access to it. But there's no way I'm going to author or prescribe this to somebody because, I don't know, they're in a wheel. It's ridiculous because the data is very clear. It is not abused.
And an expansion of that question is, have you heard of any issues where it being illegal or for doctors to be in danger for discussing medical aid in dying in states that don't currently have legislation?
Well, if a state does not have medical aid in dying, and again, as I mentioned, there are 2 states now that have dropped the residency requirements. But I don't anticipate that doctors in Texas or Illinois, well, Illinois might have a law, but Texas, Alabama, Mississippi, I don't think this is part of the discussion. I hope they're talking hospice care, they're talking palliative care. But I think it's somewhat fruitless in states without medical aid in dying to go into the weeds on this. I would love to have physicians be more educated and say, "Oh, right, maybe I've practiced in Texas and I've heard of that law, and here's some of the data that I've been able to pull together." I don't know of any law that says it's illegal to discuss. I mean, what's in the patient-physician exam room is really confidential, and I hope nobody's recording that. But yeah, this is an interesting world we're living in. But I don't think it's wrong to talk to patients about, especially in states where medical aid in dying is legal. That is an option, and letting them decide what they need to do. But in all the other states, I really, really hope they have a conversation at the end of life of, here's what we can do, here's how we can help. And I'm optimistic we'll see more states pass laws, and this will become hopefully something that is not controversial in the future.
Fantastic. There's a great question. I think this is a really important one. How have you handled situations where family members may strongly object to an individual making this decision for themselves?
Great question. And I'll give you a quick example. I had a lady had pancreatic cancer, and she drove from Colorado Springs, about 2 hours from Fort Collins. And I met with her, and she said, "All right, I've got this disease." Now she from Japanese descent. I learned that later. She was 100 miles away when the Hiroshima bomb was dropped. Amazing story. But she said, "I've got this diagnosis. My doctor, my oncologist said I've got 6 months to live. I don't want to. I want the medication." I said, "Well, you don't look that bad to me. I looked through all the data, and it sure was clear that she had this disease." Well, I qualified her, and she said, "I want the medications on hand." Well, guess what? 2 years goes by, and I get a call from Colorado Springs, and they said, "Oh, she is now needing you because we're not going to help with this. Would you be willing?" And I did. I was willing to drive down. All the way down, she was talking to me. When I got there, she was comatose. But the interesting thing, to answer this question, her son was very, very religious, very, very Catholic. And he was praying that something would happen. And not that I'm saying that happened, but he was absolutely opposed, but he supported his mother. This was his mother's decision. And he saw that he would support her, even though he was opposed. In this case, she died peacefully after about 6 hours, and he was gratified that she didn't take the medication. Another case where I took the medication back with me. But there you go. I look at this, and some dysfunctional families, yes, children will argue and be angry. But I look at my job is taking care of the patient, not taking care of the children unless they're my patients. But they can't dictate what their parents do, in my opinion. But you have to take that on a case-by-case basis and what the family dynamics is. And I'm sure there are patients that would want to take this medication but won't because their children would be so opposed.
Absolutely. Person-centered care and autonomy. We all hope for that, right? Can you talk a little bit about how end-of-life doulas may support this opportunity?
Oh, absolutely. That's another wonderful resource that is relatively new. I am friends with several doulas. I mean, it's interesting. You have the entry to life, the midwives, and the individuals that are a little bit more supportive of pregnant women in their pregnancy and their newborn experience. This is a perfect example of that same support as patients leave this earth. And they are able to do many, many, many things, including improve the dialogue, hopefully work more with the families. I would imagine there are doulas that don't support medical aid in dying. The doulas that I know do. But again, this is optional. And my view of life is that, again, let's allow patients in stressful, difficult situations the autonomy, but let's also give them as much support and option as possible. The talk I had earlier today was on we adopted a resolution in Fort Collins on universal health care at the Larimer County. And I was just looking, boy, that really helps when you have access to health care. So access to doulas, access to hospice, access to palliative care, access to health care, all valuable and really critical when you're dealing with a end-of-life situation.
Fantastic. Is there a resource to finding doctors and pharmacies or even hospice providers that are open to offering this as a choice, or is it all strictly word of mouth? Where can people go to get more information?
Right. I think there's no posting of here are the physicians in Colorado that have prescribed. I think that would be difficult because I have colleagues that will offer this, but they're reluctant to advertise it, and that makes sense. I mentioned ACAMAID, ACAMAID.org, American Clinicians Academy of Medical Aid Dying. Dr. Shavelson, the runner of that site, fabulous physician, has a process where patients can put in information, and there are physicians that have indicated in that site their willingness, and he can try to connect the two, but there's no listing of all the physicians. There's no listing of the pharmacies. The most important thing, and this is where it's important, as I mentioned, that one patient who said, I know your position on medical aid dying, and that's my position on medical aid dying, so you're my doctor. So ask your clinician, ask the hospital system. This is something we really don't want to do in hospitals because it's kind of insane. This is much, much, much better. As I mentioned, if you can die peacefully in your home, in your bed, that's great. But ask the providers. I know it could be difficult at times, but if you're in a state that has a law, I actually heard from a lady who said, when I was with my mother and she wanted medical aid dying in Colorado just a year or two ago, and the doctor said, well, that's illegal. And it was like, no, it's not illegal. It's legal. So there's still a need for education, but ask your physician, look at the healthcare. If you're enrolled in hospice, ask them. We're hopeful to get information in their website that will indicate their willingness to participate, or at least allow their staff, like nurses, to be at the home. We're seeing that bridge, that edge, begin to move a little, where this is becoming more acceptable. But I think the best way is ask. And if you're really looking that this is an option, you need to find those providers that will be willing to help.
And a short follow-up to that question is, this is mainly occurring in private homes. Does this happen very frequently in formal care settings like hospitals or skilled nursing facilities?
Very infrequently. And again, nursing homes, again, policies are different, and again, they have their philosophy and their board of directors and their groups. UC Health will allow this, but only in a situation where it's unrealistic to discharge the patient. They're so sick, they need to have care. But generally speaking, and it just makes sense. Who wants to die in a hospital? I'm sorry, I'm a physician. I think hospitals are great, but the whole intent of a hospital is you walk in and hopefully you walk out. But when you know that you're not going to be able to walk out, hospitals aren't the best place for people at the end of life. But I think, again, you're going to see this in a private setting in the patient's home. There are movements where people have limited resources, where generous folks are opening their homes up so people can come in. You really don't want to do this at a hotel or anything like that. That just is insane. But if you can find support, and then if you don't have a home, we're finding more and more options where people are seeing the need and opening their home up to allow this to happen.
That's amazing. Well, Dr. Carroll, it has been such a pleasure to talk with you and to learn from you. We want to thank you and Compassion and Choices for bringing this webinar to our audience. We do want to remind everyone that you will not be able to access the CE application for a minimum of 2 hours after this live event. It may take a little longer, again, because we do have a large audience, You will be receiving an email with the link to that CE application, as well as a link to the slides and to the recording. If you have any questions about the webinar, please feel free to email us at info@asaging.org. You can also be sure to check out our upcoming webinars at asaging.org, including the Advanced Care Planning, Education, Empowerment, and Advocacy, and the role of doulas at end of life. So very much compatible to today's talk. If you would like to share today's presentation with anyone, the CEs, again, are available for the next 60 days, but the recording will be available for a year. We want to thank you again, Dr. Carroll, and to Compassion and Choices, and we hope you will all join us again for another webinar soon. I hope you all have a wonderful day.